Mike, could we talk about Repatha? Is that how you say it?
Yes.
So that's the contract that you initiated with Amgen,
Correct.
right? And there was a deal where if the patients didn't meet the thresholds established during the clinical trial, you would get some additional discounts, or tell us again how that would work.
So, this is something.
This was a cholesterol drug.
We're talking about going from theory to practice.
Yep.
And by the way, I could not agree more on the patient outcomes. It's just, they're more complicated, but to use a non-pharmaceutical example, there is an effort in Sweden. They do all the really cool stuff in Europe for some reason, where for surgery for spinal fusions and back surgery, 20% of the payment is tied to pain score afterwards, not measures of infection or other things, but are people free of pain, which is the point of the surgery. So there's a lot of models out there illustrating we can do better. So we now have actually 3 agreements for outcomes-based contracts that are public. We have another 3 that we have signed, which are not public. We'll be sharing them shortly. And then we have, I can't even tell you how many, that are in various stages of discussion, whether with AstraZeneca or many of the top pharma companies. So while there are problems, I'm really gratified by the fact we're having collaborative discussions. We're at the table together. We're talking in rooms about how do we solve our common problems, which is ensuring that our members, our patients, have access to drugs. We've been talking about this for a while, mainly talking without any action. And really the predicate for this is thinking about what a good job we've done in Massachusetts of bringing everyone together. We're fortunate to have very sophisticated provider systems capable of taking risk. We have innovative payers. Everyone's coming together and getting it, and we have a number of models by which physicians and other providers are taking risk to some extent for outcomes. In fact, most of our providers in Eastern Mass are in some sort of outcomes-based agreement. Yet pharmaceuticals has lagged. So we've been out there talking about the concept with pharma companies about how do we move toward paying for value, just like everyone else. And Amgen was the first to step up with the introduction of Repatha. Essentially at its core, there is a rebate for preferred access to Repatha over another drug, Praluent. But the more interesting part, and part of why we chose Repatha from Amgen, is a portion of that is tied to whether it actually reduces cholesterol to the level seen in the clinical trials. That was a function of a number of discussions and then ultimately bring us something structured. But since then, we've signed agreements with Novartis for their CHF drug Entresto. We talk about value frameworks. Entresto is expensive, about $6,000 a year, a lot more than the generic ACE and ARBs. Is it worth it? Well, ICER came out with a report saying pretty much that's a fair value. So people like myself and other CMOs sit around saying, not how do we keep people from that drug, but it's a shame that more people aren't on it. And in fact, what makes it even better for this Novartis drug is part of why it exists. It's been shown to reduce hospitalization for CHF, which is expensive and really bad for people just on a quality perspective. Well, they put a certain amount of dollars at risk, so the price of the drug is effectively less if we don't see the reduction in hospitalization that they promised. Similarly, we have an agreement, for example, with Lilly for Trulicity, which is a GLP-1 agonist, a drug for diabetes. What I really like about that agreement is it actually is not just tied to some arbitrary reduction in blood sugar. It's actually predicated on whether people on their drug do better or worse than those on the competitor's drug in that class, which is really groundbreaking. So the fact we're having these discussions is a positive. We have many more dialogues underway. It's very common, and one of the questions people ask, how does all this stuff come together? Well, the fact is that frequently we have many pharma companies come in, we sit with a whiteboard, we try to understand where their positioning is, explain how we construct our formulary, what measures matter to us. We're seeing 3-way agreements with dialogues. A few weeks ago, a major pharma company, which I won't mention, came to meet with us. They brought some providers, the MGH Cancer Center, because they heard us say we're interested in how we can do a better job of ensuring that people get the drugs they need for cancer, where the drugs are really expensive and arguably worth it if they work, maybe worth less if they don't work. So these discussions are underway. It's very exciting, and we're seeing a large backlog of potential deals coming out, which I think will solve some of the problems that we're seeing.
So Diane, I don't think you've actually been in, have you been in the room with Michael in front of that whiteboard? You haven't, right?
Our teams have.
Okay.
We have 3 different
So we're gonna sort of be in a hypothetical space here. If you're sitting in that room and you're looking at the whiteboard, what do you see differently than he does? He just described, Michael started to describe an equation.
Yeah.
What parts of it do you want to be sure people understand
Great.
has to work for you?
So we both see the same thing. We're looking at the same whiteboard largely. What we bring to the table is, what is the incidence and prevalence that we've studied? So we do a tremendous amount of research in how many patients are out there, what are their ages, demographics, who have we studied in the clinic, why have we studied them, and we compare that with our customer. So Harvard Pilgrim could be a good example of, okay, then how many patients would they have? So maybe they have 100,000 patients with an oncology treatment. And then
because what looks like revenue to you looks like expense to him, right?
Well, there's really no revenue yet, right? Because we haven't figured out who the right patient is. So then we go through, how do you currently test? What should we be promoting in terms of testing? There's a lot of new diagnostics coming, which is incredibly helpful to find the right patient. So we go through the process of, okay, who are the right patients that we're going to agree to? We actually are working with one customer to help them forecast 2 years from now how many patients will there be in a certain disease, so that they can do their actuarials. So we do that first. We figure out, okay, who's the right patient? Then we really look at what we've studied, and then what our medical folks from their customer, our medical teams get together and they decide, okay, what is the right course of treatment? What's current protocol? What's in the literature? And what risks should we take as a pharma company based upon our label? So I'll give you a good example. We have a product, readmissions is a huge issue. So patients with ACS get readmitted. It's very expensive when they've had a stent or a heart an MI, that 30% of the time they actually take their medication when they leave the hospital. They don't really understand their medication. They can get readmitted. So what we've agreed to with one of our health systems, again through a whiteboard discussion, is if a patient is readmitted after a month and before a year, which is in line with our label, the patients that we studied, then we will pay for that readmission. And so we're standing behind the medicine. What we have to do together is make sure that the patient gets on and stays on therapy, which is the issue, right? Is making sure that they really understand that they take their medication. So they come in all shapes and sizes, but they're very, very collaborative. I think to Dr. Sherman's point, we sit in the room and we're all trying to solve the same thing, and that is helping that patient understand and afford and get on this therapy. And then we look at the outcomes to see what's working and what's not working. In ACS, we've gone through 4
Diane,
iterations
can I just
now.
pause and would you mind,
Absolutely.
Michael, get right back to you, but Maureen, I'm just curious, should the patient know this is all happening?
That was exactly what I was thinking, is how do we bring that conversation to the point of care? Or how do we kind of translate that this is part of what the challenge is, and make sure we're integrating that, because maybe the patient isn't informed of how challenging it can be to take the medication, or how are we communicating that to the patient so they understand their role in this as well, to make sure that they're getting the full value of the medicine that they're supposed to be taking.